Professor Franklin, before we come on to HCV testing, there's just a few other questions,
Yep.
some of which have been suggested by call participants. Could we look, please, at NHBT 0046145017? We can see this is a letter addressed to you from Dr Alla, the Director of the West Midlands Regional Blood Transfusion Centre, September 85, and he says that he's learned a plasma contributor to unheated factor VIII of a particular batch, belongs to a high-risk group and is now HTLV3 positive, and you're asked to identify and follow up haemophiliacs treated with this product. And then it says Dr Krask is prepared to provide advice regarding follow-up, would be glad to have a copy of the relevant patients' names. If we could then look at the reply that's sent on your behalf, it's NHBT 0046145002. We can see from this, it's sent by your secretary, 18th of November 1985. It's addressed to Michelle. I'm not sure who that is, but this would appear to be a response to Dr Alla's letter in any event.
Dr Alla's secretary, I know well, yeah.
And it says the haemophiliacs who've been treated with factor VIII batch number HL2882 are as follows. And we can see from this, although we've obviously redacted the names of the patients, that you've listed or there has been listed on your behalf the names of the patients and their HTLV3 status. Now, do you know whether the patients themselves were asked to agree to that information being sent to the Regional Transfusion Centre?
I don't know the answer. I don't remember the letter. I was surprised to see it. The names shouldn't have been on. There was no reason for Dr Alla to know the names. And I apologise to the patients whose names are on there. I don't understand how that letter went out, but
more generally, in terms of information that was provided to other agencies or organisations, we know obviously that information was sent to Oxford at this time, later to the UKHCDO National Haemophilia Database in Manchester. We've seen documents from other centres, some of which identifies patients by name, gives patients details. Can you recall whether you ever discussed with your patients the sending of information about them to Oxford and asked for their agreement or not?
if we go back to the pre-HTLV testing era, I think information was shared. I have to say, I think at that time it was not an unusual practice. There was an organisation, still is, called the International Bone Marrow Transplant Registry, and at that time I was supplying details of patients' transplants to that organisation, and at that time I don't think the patients were told. Eventually that changed and that did happen. So I suspect that prior to HTLV testing, that did happen. My recollection with working with Frank Hill, that we were unhappy to share those sorts of details. I don't think we would have been unhappy to share numbers of cases, numbers of people. But there did seem to be, and there is quite a varied mention, it crops up a few times in the papers about the desire of Dr Krask on the one hand, I think at one point Richard Tedder, saying that they need to have the names to make sure they're not double counting. I'm pretty sure that from the beginning Frank Hill and I didn't agree to send those names. I think I've seen another report from Geoffrey Savage saying that he wasn't prepared to do that. What I can't tell you is when that, if it ever did get resolved, but I know it went on for a few years when we refused to send the names.
And do you...
So we did have an awareness that it wasn't, to our minds, appropriately secure information that they were requiring.
And do you recall whether you ever discussed with your patients?
No, I'm
that
afraid
issue?
I don't. Well, I think we didn't.
And then in paragraph 27 of your statement, it's WITN 4032001. I'll find the page number. Yes, sorry, it's page 27, Henry. It's the third paragraph. You talk about the time when HIV became a recognised additional risk factor for severe liver disease. Could you just explain a little more about the relationship between HIV, AIDS and liver disease?
Well, we started seeing people with severe liver disease, and they were all people who were dually infected. Well, we didn't have a test necessarily for hepatitis C, but they had non-A, non-B hepatitis, and they had HIV. People who were HIV negative didn't seem to be getting that.
So is this right? There appeared to be a more rapid development of severe liver disease in patients who were co-infected.
Yeah, I mean, precisely, I can talk about the sort of temporal thing, but yeah, certainly the ones that were getting severe liver disease seem to be the ones who are HIV positive.
And then, I don't know whether you can answer this or not, Professor Franklin, but do you know what impact liver disease can have on the body's natural production of factor VIII?
Well, if you do a liver transplant, it immediately corrects the deficiency, but that doesn't come from liver cells, it comes from blood vessels, as I remember. Gosh, I think. So I'm not too sure it has a huge impact, but I may be wrong.
We can ask others in any event about that. Can I move on then to HCV testing? Your statement says you don't recall testing patients for hepatitis C before you left in 1992. We're hearing from Dr. Wild, who took over at the centre after you left this afternoon.
Yeah.
But his statement sets out his recollection that the testing, or much of the testing, had been done before, before he arrived. So are you able to assist any further with what happened with HCV testing?
Well, I've been concerned about this. I can't remember doing it. And I'm concerned on a number of levels. One is because looking at the timing, we should have had testing available. Secondly, I would have been keen to look at some of my other patients, my transplant patients who were heavily transfused. Almost certainly some of them would have been HCV positive. And also my patients with sickle cell disease, a small proportion of whom were also heavily transfused. So I was hoping that there might have been some documents come through to jog my memories, but I must apologise, I can't remember.
So I think, would it follow that you can't remember whether the arrangements were patients notified in advance, stored samples, or specific?
I can't remember doing the tests, I'm afraid. Let alone whether I told people beforehand.
In terms of research, you've referred in your statement to certain studies or trials with which you were involved. I'm not going to ask you further about those. As far as you can recall, did either the Queen Elizabeth Hospital or the Children's Hospital have any involvement in the trials of so-called hepatitis-reduced factor concentrates that were being discussed by UK HCGO in the early 80s?
Well, you've provided information to say that I obviously contributed to the 8Y study. I don't remember doing that. But if it says that I did, then I did. But I can't think it was many patients because the requirements were for minimal treatment, I think, not necessarily previously untreated, but minimal treatment.
And when you started as director in autumn 83 and in the course of 84, can you recall involvement in any particular trials or studies in that first year and a half or so of your time?
I can't remember any, no. Don't think I did. But
What general interactions did you have with pharmaceutical companies in that period, 83 to 92 at Birmingham?
In terms of factor 8, quite limited. You provided some documentation to do with Qatar. I think over time we did speak to the people. I had a closer relationship with people from Alpha, not to do with their factor 8 particularly, but with regard to their immunoglobulin products, which I was interested in using in the bone marrow transplant patients to prevent cytomegalovirus.
Did you receive any kind of funding at QEH from pharmaceutical companies, whether for training or educational purposes, or funding staff members, or anything?
I don't remember any, no.
And if we have up on screen, it's a document I referred to during the presentation yesterday morning, Professor Franklin, so might have seen reference to it then, although it wasn't sent to you before your evidence. It's ARMO 40370. This is a letter to Professor Hill from ARMA in March of 1985. And it says, I've paid our first 1985 donation to your research fund, to the finance department of the Central Birmingham Health Authority. Did you have any knowledge of a research fund as part of the health authority or the centre?
No, but it doesn't particularly surprise me. I mean, I knew that Frank Hill had an academic interest in, more specifically von Willebrand's disease, but in bleeding disorders. So, and I had no knowledge of that. No.
And did you have any equivalent fund yourself?
I had equivalent funds, but not from companies doing factor 8. Did I have any from companies? I don't remember any. I had funds from individual donors. There was the father of a patient who had a bone marrow transplant, gave me a very generous donation which went into one of these funds, but it wasn't for or in relation to haemophilia care.
Okay. Do you recall giving any information to pharmaceutical companies about patients' HTLV3 results, either individual patient data, or did you communicate how many patients were HTLV3 positive to pharmaceutical companies at all?
I don't think I would have ever have done that. I'm trying to rack my brains about the Armour episode, whether it's possible I might have said I don't think we've had any problems, but I don't remember anything.
When you said the Armour episode, you're referring to the seroconversion on heat-treated
product that had infected a number of children at the Children's Hospital. I don't even remember whether we used that batch at the Queen Elizabeth Hospital, but I couldn't possibly say it would be impossible that I might have said we haven't had any transmissions.
You were asked yesterday by the chair about a letter that had been sent to Professor Hill from Trelaws, reporting that one of the Trelaws boys who was a patient of Professor Hill showed signs of AIDS stigmata, June 1983, and you commented it was vital information. This may have been implicit in your answer, but can I just double check? Is it the case that you weren't given that information by Professor Hill at the time?
I don't remember him mentioning anything about that so early. I've been reflecting on the issue overnight, and I wonder whether he didn't tell me because the young man was not going to come to my care when he got older. I don't know, but I would have thought in general it would have been important information to know that a patient was showing signs of stigmata, I think was the phrase, of HIV, yeah.
So as far as you can recall, that isn't information that was ever shared with you?
No.
Can you recall any discussions in the first part of the 1980s, whether with Professor Hill or otherwise, about pool sizes and the risks from pool sizes?
Which year, sorry?
In the early 80s.
Oh, well, my difficulty here is that it all gets a bit tied up with my subsequent knowledge from working in the blood service. But my recollection was that the pool size in the UK was lower, and that the pool sizes from the United States were much higher. And of course that, for a low-level risk, would make quite a difference. But that's about the level of it.
And then in terms of the early attempts to heat treat before the December 1984 change of policy, both from UK HCDO and from West Midlands, in the course of 83, 84, up till December, did you have any discussions with anybody about using heat-treated products or obtain any information about the availability of heat-treated products?
I don't have any recollection of that. And in fact, the first I realised that some of the haemophilia centres like St Thomas's and Sheffield were using them from the middle of 84 was when Mark Winter gave his evidence.
And you've referred in your evidence already to certain knowledge about the donor population in the States, and the World in Action documentary in the 70s and so on. Did you have any information or seek to find out any information about the donor pool in the UK and whether there was any use, for example, of blood from prisoners in the UK?
At that time, no. There was use of blood from prisons in the UK. I came to know quite a lot about that subsequently. In fact, the collection of blood from prisons in the UK was encouraged by the Home Office as part of a social inclusion process for people in prison. It later became, not that much later, it became clear that there was a lot of hepatitis B in prison populations. And the use of prison donors was phased out variously in different places. I think by 84 it had all finished, but I may be wrong. I mean, I haven't mugged this up for you, but...
That's later. Knowledge you acquired later, is it, rather than knowledge you had in 83 or 84?
At that time, I think I had no visibility about prison donors, no.
And then you've made reference in your statement to the precautionary principle, and I just wanted to explore that a little with you. As I understand both your statement and the principle more generally, it's a principle of adopting precautionary measures when evidence about a hazard to human health is uncertain or unclear.
Yes.
So in colloquial terms, one could say one errs on the side of caution.
Absolutely, yeah.
And it means you don't require proof in order to act. You may act on the basis of suspicion or concern.
Well, yeah, you would work on... Well, you might look at the worst-case scenario and think, what's the best thing to do to avoid that, yes.
And so that I can understand the observations you make in your statement. You contrast some of the decision-making in the 80s with what happened in relation to VCJD in the 90s. An approach such as that seen from Professor Bloom at that October 83 UK HCDO meeting, there's no proof. That's not an application of the precautionary principle.
No, it's the opposite. I mean, it's saying, there's no proof. It's a bit, reminds me a little bit about everyone here is wearing a mask. And at the beginning of the COVID-19, there was no evidence that masks were helpful. However, it might have seemed intuitive that masks could be helpful But it wasn't until some evidence appeared some months later that we all wear masks. It might have been better if everyone had worn masks in February onwards. But.
And then in your statement at page 87, Henry WITN 4032001, you've touched on this already, but you've said what happened to the people with haemophilia was terrible enough regarding the virus infections. It was made so much worse by the failure of authorities at so many levels to provide support for them or their families. And then you refer to the refusals of funding of facilities in Birmingham and the West Midlands, and observe perhaps this had something to do with the stigmatisation of people with HIV and the then guilt by association with groups perceived to be unworthy. And then you contrast that with the response to VCJD, which seems so different. A support package was put in place to provide medical support and financial security to those affected. There seemed to be an acceptance that government policy in respect of changes to animal food practices had contributed to the condition. Does it follow from the observations you make there that you think more could and should have been done to provide both financial and non-financial support to those who were infected through their NHS treatment?
Yes. Yeah, I do. I mean, what I perhaps hadn't realised was that there'd been clearly a reluctance to provide funding for haemophilia care before all this. In the I can't remember whether you included this in your presentation, but in the papers that were provided, it was quite clear that Dr. Hill was trying to get more support. There was talk about a nurse was funded by the Haemophilia Society for a year and then not taken up. So I think there's clearly a history of that. You do see comments in, I can find them for you later, but comments from people saying that it's a very small number of patients for an awful lot of money. And this is, I'm not talking about HIV here, about the provision of factor VIII. And so I don't really understand why there was such a reluctance to provide the support, particularly by 86 when the money was available. And perhaps I shouldn't have used the word stigmatisation, but I just wonder why there seemed to be such a lack of humanity shown by people in senior positions in the West Midlands Regional Health Authority, to be blunt. And that wouldn't have helped the infection. That required major government input from, well, you've heard from David Owen. Self-sufficiency earlier, that would have made a big difference to HIV. It wouldn't have completely eliminated it, but it would have at least shown the people with haemophilia that efforts have been made rather than nothing. And once it had happened, you'd have thought that the least that could be done would be that you would provide decent services with people. And as I say, without wanting to go on and on, I think the issue with variant CJD, thank goodness, turned out to be a small-ish problem. I apologise to people here who've been notified that you might have been exposed, but it looks as if it's going to have affected about maybe 200 people at the most in the UK. But the government didn't know that when they put the package in place, and it could have been many, many thousands. And so I think that was a good way of dealing with it. I spoke to one of the members of staff, one of the nurses at the CJD surveillance unit in Edinburgh, who was responsible for administering the support scheme, and I found out a bit about it, and it seemed to be working very well. It's a terrible disease, terrible in a different way from HIV, but still terrible and fatal. It just seems that at every stage there was any opportunity was taken not to help.
My last question, Professor Franklin, is just about the patients with sickle cell or bone marrow transplant patients whilst you were at Birmingham. Do you know whether any of them, and if so, in what number, were infected with HIV or hepatitis C?
No, I don't, but I can estimate that probably about 20% of the transplants patients who were still alive, survivors, would have been infected. That was a figure in Glasgow.
With hepatitis C?
With hepatitis C. We had one patient in Glasgow who was infected with HIV.
And the sickle cell patients?
I don't know, but I would imagine they were less heavily transfused, but I imagine there would have been a few that would have been positive, yeah.
So those are my questions for Professor Franklin. Is there anything so that you wish to ask?
Yes, there is. What I want to do is to ask you about 4 matters which arise from some of the evidence which you've given.
Yep.
The first, did you have any working knowledge or understanding of hepatitis B when you took up your post in Birmingham?
I didn't have a lot of personal I didn't have a lot of personal experience other than that a colleague in University College working in the labs got infected with hepatitis B, and it turned out that later on that I'd been exposed to hepatitis B. I mean, that just reflects poor lab hygiene in the late 70s, I'm afraid. I had a very good understanding of the natural course of hepatitis B from Dr. Barbara in my transfusion training. So yeah, it was pretty reasonable, I would say. The vaccine came in at about that time, so had to do a bit of catch up with that. But yeah, I think we were pretty aware of the risk of hepatitis B and checking patients and offering the vaccine when it became available.
So you would have had an understanding, at any rate, that it was highly infectious.
Yeah, very, very infectious.
Transmitted by blood.
Yeah, yeah.
Was sexually transmissible.
Yep.
And people needed to know that they had it if they could be told, because they might go around infecting other people. The reason I'm asking you about that is because you told us that you knew very little about HIV infection when you first came across that, and you didn't know much about what might be the natural history of it, what those who suffered from HIV might expect, and what advice they should be given. One of the comparisons which I understand was made in the MWR from the earliest days through, and you were reading that at the time, was that the outbreak of AIDS seemed to have quite a lot in common with the epidemic there had been of hepatitis B. Did that ever occur to you as giving you some clue as to what might happen with the HIV infection and AIDS? Well, you didn't know it was necessarily HIV infection, but with AIDS and whatever was causing it in 1983-84.
Well, I'm not sure the two are quite such a good parallel. I mean, there's no doubt that a lot of the hepatitis B cases in the States, there were major epidemics in gay men. And in fact, I remember the publications to do with the vaccine in gay men in the States described the number of sexual partners that they had, and it was a very large number indeed. I'm not quite sure I accept the analogy. I mean, HIV is a lot less infectious than hepatitis B, other than perhaps with gay sex. But, and also the natural history is quite different. I mean, I think when I was saying know much about HIV, I think we didn't know the natural history of the disease. It was sort of very early on. Was one thing I was taught by John Barber was what the natural history of the disease was. Most people clear it. Some people become carriers and remain infectious long term. And it was known that some people, well, quite a lot of people, went on to get hepatocellular cancer. So, does that answer your...
Yeah, well, it does. I was curious about whether that might have given, as it were, some help.
I certainly think the gay population, I mean, obviously that was a time of, another tragedy was that, we had gay emancipation and the beginning of removal of some of the stigmata, and then stigmatization, sorry. And yet, and then AIDS comes along. Yeah.
Well, the second matter is something completely different. It arises out of the discussion that you and Council had about the question of consent. And what you said in your statement about the process of formal consent being rather different in those days. By formal consent, I think you mean signing a piece of paper.
Yeah, yes.
And the 4 different words were used: telling a patient, discussing with the patient, mentioning it to a patient, or agreeing with the patient.
Right.
Now, I just want to be as clear as I can be about what your practice was, and I appreciate it may have differed from person to person, and you're not able to say with certainty it was adhered to in every single case as a matter of rule. But would you say that there are 2 separate questions? One is consent in the sense of agreement. So somebody agrees to a course of action knowing the broadly the relevant matters which will tell upon whether they agree or not.
Yeah.
That's informed agreement, if you like. And it doesn't matter for the quality of the agreement whether it's recorded or not. It might be said. There's recording, which, if it's not carried out carefully, may become a tick box exercise.
Mm-hmm.
And that itself is a danger, because it means there's evidence that there's been consent, but actually there hasn't. It's just a box ticked, as it were. So, did you, as far as you can recall, would you have aimed for informed agreement, or a tick box exercise, or somewhere between the two, mentioned or discussed? Discussed, I suspect, means informing, but there's no end product of the discussion. It's just chatting about it.
Well, I think we were aware that testing for HTLV-3 HIV was a big issue. So I think I would have been expecting to reach a sort of mutual agreement that this was something that the person agreed to have done.
And by saying reach a mutual agreement, you were discussing the pros and cons.
We would have been discussing the pros and cons. There wasn't at that time a clear view of exactly what it meant. I know that when you look back, it seems obvious that a positive test meant you were infectious. I'm not actually sure it was as clear at the time that was the case. And we certainly didn't know that nearly everyone who was positive would go on to get AIDS. So there were these different things. There was a growing awareness of worries about stigma, insurance. So I think it was important that the person agreed. And I do remember a small number of people who decided they would rather not have the test at that time, but they did come to agree. I mean, consent is really very important. At around that time, I had introduced a formal consent process for bone marrow transplantation, because at that time in the NHS, the only written consent was for operations, and it was a single sheet of paper, and the person was expected to sign saying that they agreed to whoever did the operation. It could be anybody, not necessarily a named person, and they were consenting for anything else to be done that was considered appropriate. Now, that we now know is not any sort of consent, and that's been tested in law and doesn't work. But that was all there was then. So I produced a document. I think the hospital were a bit reluctant for me to produce this because it said to the patient that they would lose all their hair, that they would become sterile, that they may die, and listed some of the complications. So trying to make sure my patients understood what was happening to them was important to me, and I still feel confident today that I got reasonable informed consent from them, albeit verbally and in discussion.
Yes, well, thank you. That answers that question. Third, you told Council that you were surprised by the practice which you understood to have happened in other centres, or some other centres, of calling together people in a group in order to inform them as to HIV status, positive or negative. Can you elaborate on what you meant by surprised?
Well, I'm surprised because I still struggle with the concept of how you would do that while protecting people's confidentiality. And I suppose you could ask people to come to a sort of lecture room and just do a neutral presentation about AIDS, HTLV3, or non-A, non-B hepatitis, whatever. But I think the difficulty then would be to maintain some sort of clarity as to what you were trying to get across. If some of those people in the room were negative and some of those people in the room were positive, or you didn't know, perhaps doing that before you knew might work. I would think it would still be quite difficult.
So you might be calling people together and saying you're at risk.
Well, it maybe the time to do that would be to say you were at risk and there is a test coming.
Yeah.
When I think back, that might have worked. Even so, I'm not sure. But yes, I remain slightly surprised that happened.
Yes, thank you. The final question is your discussion you had about the precautionary principle, and in the course of which you mentioned, I think, that you knew quite a bit about, or just before that, you mentioned you knew quite a bit about pool sizes now, presumably from your subsequent experience in with the Scottish.
I think it's difficult for me to separate when I learned these things. Yeah.
Your understanding of pool sizes is that the NHS pool size was smaller than the US pool sizes. I'm yet to have a presentation given to me or information given to me on what our researchers have shown as to the development of pool sizes from the early 1970s through into the early 1980s. But it may very well be that the pool size used by the NHS blood transfusion service, I don't know if you know what happened to it. Do you have a sense that it increased during that time?
Well, I think throughout my time in Scotland, my recollection was that the pool sizes were between 5,000 and 7,000 donations. I don't know what happened in BPL. I suspect that, to be honest, as much of it was to do with the size of the facility. The Scottish facility was always modest in size, and we had a modest population to serve 5 million, plus Northern Ireland, so 6 million. So I don't know the answer. I know when the concentrates were first used, which was actually in the 1960s, non-commercial in Oxford. They were really very small sizes, less than 300, I think.
So in England, at any rate, the pool sizes may have gone from just less than 300 in Oxford in the 1960s, as you said, and increased in size into the 1980s.
Well, I'm sure they did, because it's inefficient to use very small sizes, yeah.
So, throughout that period, it was recognised that the larger the pool, the greater the risk of infection from whatever might be in the pool.
Well, that was what was... I think there were lots of things that were believed. I think the pool size was one of them. Smaller pool size, unremunerated volunteer donors. So each of those might have an impact on the risk at the other end. But if you, unfortunately, what turned out to be the case was hepatitis C had the prevalence in the general population of around about 1%. The restrictions on blood donors reduced that by almost tenfold, so it was around about 1 in 1,000, I think. So even if you've got a pool size of 5,000 versus 20,000, you're still going to be having virus in there. What benefit having less virus? There might be some benefit. You can't help thinking it would be better to have less virus than more virus. But when you come down to HIV, then the differences would be more relevant. And I think one of the issues around the ARMA heat-treated product was that my understanding is that the plasma had not been tested for anti-HTLV3. So it was not clean plasma going into that process. And the heat treatment was required to kill too much virus, and it couldn't do it. So some of it got through. So at each step, you need clean donors, good testing, modest pool size. All of those things are going to contribute to safety, I think.
And in respect of your discussion about the precautionary principle, what do you think that might suggest to the concept of increasing pool size whilst an appreciation of risk from pool size was growing?
Well, I suppose it's a really difficult question, because you've got a continuum between the pool size of cryoprecipitate, which is between 10 and 20 perhaps for an adult, right up to 20,000. So the precautionary principle might suggest we should have stayed with cryoprecipitate, I suppose.
Well, thank you very much.
Professor Franklin, is there anything further that you would like to add?
No, thank you for mentioning the my comments at the end about the appalling thing that happened. It was a very difficult period, but the patients were amazing, showed great fortitude.
Thank you.
Yesterday afternoon, when I was apologising to you for bringing you back for a second day, you told me that you were here to help.
I hope so.
Some people might use that to just as a form of words, others to ingratiate. I believe that you said it because you meant it, and I would like to thank you for your contribution, because it seems to me you haven't pursued any agenda of your own other than helping the inquiry. You haven't shirked questions because the answers might be uncomfortable. You've given us, I think, as I see it, frank, refreshingly frank, open and honest answers to the questions which you've asked, and I think that deserves appreciation. Thank you very much.
Well, thank you for your kind words and excellent chairmanship.
Well, I hope that's that's not because of those words, but
No. But I've you've been very searching, but positive, I think.
Thank you very much.
So we have Dr. Wild's evidence at 2. Dr. Wild will be giving evidence remotely
Yes,
for reasons of geography and the current pandemic.
of course. So 2 o'clock, back here for Dr. Wild.